G'day everyone, it's Dr. Joe Sgroi here. I'm doing a Facebook Live on behalf of Melbourne IVF with respect to recurrent miscarriages. Hopefully we'll have a fair few people joining us over the course of the day. And so for those of you who have experienced recurrent miscarriages, of course, for a lot of people that's quite distressing, and the most important thing that I'm going to say to those people who have unfortunately had recurrent miscarriages is, in fact the very vast majority of the time, is really to have a strong supportive network behind you, particularly with respect to counsellors. Of course, a good fertility specialist, obstetrician and or gynecologist is going to be particularly important in being able to support you during what is a very difficult journey. I think it's really important to normalise miscarriages, and a lot of people who are jumping online now will have unfortunately had a recurrent miscarriage or recurrent miscarriages or a pregnancy loss, and unfortunately it's not talked about too much in the media, whether it be social media or the general mainstream media. But the reality of the situation is that approximately 15% of women will experience a miscarriage, and of course not only affects women but also their partners, whether it be male or female partner, and that can have a huge amount of psychological distress on not only the individual but as the couple unit as well. And it's no one's fault in general. Of course there are reasons as to why miscarriages occur, and so part of what we'll be talking about today are some of the common reasons why recurrent miscarriages occur, and what are the sort of treatments that are on offer in terms of recurrent miscarriages in order to mitigate against the ongoing risk. So I'll wait for a few more people to join us. So I do have some questions, and I think people can post questions if they like as well, in order to give us a bit of an understanding whether you have anything that you want particularly asked in terms of miscarriage rates, and also whether there's any treatments you want to ask me specifically. As I said before, approximately 15% of women will have one miscarriage, and where we term recurrent miscarriages is really in the setting of a woman who's had miscarriages that are inconsecutive. So it is exceptionally unfortunate, but approximately 2% of women will have two miscarriages in a row. And for those very unfortunate women who experience three miscarriages in a row, that's around about 1%. Now, the vast majority of units around Australia, in fact in the public healthcare sector, approximately three miscarriages is very rare, of course. And so a lot of women will have miscarriages, and they'll have the first miscarriage or the second miscarriage, and very limited further investigation is done. I think most fertility specialists now will undertake some preliminary investigation even prior to conceiving, but certainly after one miscarriage, understanding the undue stress that it has upon an individual. Certainly in my own practice, I investigate a hell of a lot more further. And the initial fertility assessment, whether you see me or a range of fertility specialists, most of us will undertake investigations to preclude miscarriages, and we'll talk about some of those investigations in the not too distant future. In terms of miscarriages, there are many risk factors that can predispose women to miscarriage. I'm just going to see if someone's asked a question about poor egg quality. So we'll work through all of that, Kimberly. So part of the issue in terms of miscarriages is to identify what are the risk factors. And the first thing, I suppose, is maternal age. Maternal age has a strong predisposition to the quality of the eggs, but also the eggs in terms of their genetic normality, which will lead to further investigations, and we'll talk about that in the future in terms of how IVF can potentially assist women who've had recurrent miscarriages. Broadly speaking, if you think about the pregnancy as being an embryo which is like a bun, and the uterus being like an oven, effectively we want a really good quality embryo, and we want the uterus or the oven to be as solid and as receptive as it possibly can be. And so those qualities are going to be probably the most important in the couple being able to achieve pregnancy. But also paternal age has some factors in terms of recurrent miscarriages as well. And so we know that sperm quality in itself is particularly important in maintaining a pregnancy and an ongoing pregnancy. And there are some studies to suggest that sperm DNA fragmentation, where the DNA within the sperm degrades over a period of time, can lead to miscarriages as well. But generally speaking, there are broadly 4 or 5 different areas of concern when it comes to a woman, or when a woman comes and sees any of us as fertility specialists in terms of what recurrent miscarriages are. The first thing we look at is the uterus and the structure of the uterus. And I talked about having a receptive uterus. So we look for abnormalities or anomalies in the structure of the uterus. And a lot of my patients in the past have had something called a septum, or a partition that occurs within the uterus. The best way of thinking about the uterus is just think about it as a room. And you imagine a room with big thick walls around the side where you can channel in your electrical cables and your internet, Ethernet cables as well. So that means that if you're trying to plug in a device on the side, you can easily get to a electrical point and be able to plug in the device. But if you imagine within that square box room, you then have a partition which just is a plasterboard. There's no way that we can then have any cabling going up and down that particular plasterboard. So if you tried to log your computer or plug in a device onto that plasterboard, you wouldn't be able to necessarily get any electricity. And the same thing, the uterus is, generally speaking, a nice hollow structure, and if there's a partition that runs down the middle of the uterus, this can impair pregnancy, because the embryo, if it tries to implant in that septum, has no capacity to be able to develop an ongoing placenta. So we look inside the uterus often, whether it be in terms of an X-ray or an ultrasound scan, or sometimes even visualizing in the uterus itself in terms of a hysteroscopy. Certainly, I encourage you to continue posting questions, because I will answer them at the end once I've gone through everything in terms of miscarriage risks and also risk factors. So we look at also whether there's any fibroids within the uterus. And think about a fibroid think about the surface of the uterus as a surface of the MCG. And if you think about the surface of the MCG, or the SCG if you're living in Sydney, or the GABA in Brisbane, but think about the surface of the MCG, not full of nice, beautiful grass, but in the middle you place a big, solid baseball pitch that's really quite tough. You can imagine then that grass or a tree won't grow near that particular baseball pitch. And a fibroid's not dissimilar. It's a whirl of connective tissue that forms within the uterus that actually there's no way that any vessels or blood vessels can permeate or penetrate that particular fibroid. So once again, if an embryo tries to implant itself, just like a tree or grass trying to grow on that baseball pitch, there's not going to be the capacity for that particular pregnancy to continue. So often we do look for fibroids and see whether there's anything called a submucosal fibroid, a fibroid that's poaching into the cavity of the uterus that potentially can impair pregnancy. And by removing that fibroid through a hysteroscopic procedure, we increase the chances of pregnancy. So at this point in time, we've talked about the uterus, we've talked about the structure of the uterus and making sure the uterus doesn't have any abnormality within it. And if it has a septum, we can resect that septum out, just like going into a room where there's a partition and removing the partition so that the cavity of the uterus is open. If there's a fibroid, we can dig the fibroid out, a little bit like going to that baseball pitch on the surface of the MCG and actually digging up the baseball pitch and removing it, and then laying it down with new grass, new soil, and of course it would ultimately result in a pregnancy in the future. A lot of people have polyps within the uterus as well. The research in terms of polyps and whether they have any impact on pregnancy is sort of, there's you can find research papers that suggest there is a predisposition to miscarriage. Certainly there's no doubt that as a fertility specialist we will remove polyps prior to any embryo transfer to maximise the chances of pregnancy, and I suppose also reduce the chances of miscarriage. So we've talked about the oven, we've talked about where we're placing the embryo. So whether it be you're trying to conceive naturally, or alternatively whether you're trying to conceive via IVF, we're going to make sure the integrity of the uterus is normal. And for those women, unfortunately, who have had lots of miscarriages where they may have had surgical procedures inside the uterus, you can actually form adhesions within the uterus. And they're like, I suppose, bands that form within the cavity. Again, thinking about a room, if you imagine a room and now you've laid streamers everywhere and they're sort of blocking, I suppose, the cavity of the womb. We can go in there and we can remove those streamers, we can remove those adhesions and improve the chances of pregnancy. The next thing that's very common in terms of miscarriages is autoimmune, or the body producing antibodies that potentially can attack the pregnancy. And the most common of this is something called the Antiphospholipid Syndrome. And we look at two particular hormones called anticardiolipin antibody and the lupus anticoagulant. And women who have this are predisposed not only to recurrent miscarriages, but unfortunately also preeclampsia and a small baby. So if we do find these particular hormones, particular antibodies rather, these women having been predisposed to miscarriages will benefit from either aspirin or alternatively clexane. So a lot of women you'll know, particularly if you've seen a doctor in the past, they'll put you on medication such as aspirin and also clexane or heparin in order to reduce the overall chances of pregnancy. I note that someone talked about natural killer cells a little bit earlier on. And if we look at the literature of natural killer cells on recurrent miscarriages, there's poor amount of information specifically related to the uterine natural killer cells and their predisposition to causing miscarriages. And I suppose the discussion that you'll have with your fertility specialist or your obstetrician or gynecologist will be weighing up the risks and benefits of potentially treating natural killer cells as opposed to not treating them in the context of recurrent miscarriages. And of course the evidence is poor because there hasn't been a lot of research into the area. So there is a small study that looked at around 50 women and divided those women up into who had recurrent miscarriages and natural killer cells, where they gave women progestogen, aspirin and also prednisolone to try to reduce the rate of miscarriage. And they did find in the arm of women who had progestogen and progesterone, aspirin and also prednisolone or dexamethasone, that there was an increase in pregnancy rate, but that didn't reach statistical significance. And so this is part of the art of medicine, is that each individual doctor that you do see will give you a bit of a difference of opinion in terms of how to manage specifically different types of medical conditions. And so in that scenario, you may see an immunologist or a rheumatologist that will, as Julie has written here, suggest using other medication as well as such as Plaquenil in order to reduce the overall immune response that potentially might result in antiphospholipid syndrome and obviously the risks that I talked about before in terms of recurrent miscarriage, fetal growth restriction, or the baby unfortunately not growing, stillbirth and preeclampsia. Interestingly enough, as part of a fertility workup that I do for my patients, I also look at celiac disease. And untreated celiac disease can also predispose women to concerns with their fertility, but also miscarriage. So if you do have celiac disease, again, it's an immune response as well, and it's untreated, then of course that can lead to miscarriage. So reducing that overall burden of disease in terms of the bowel will also impact on the woman's capacity to be able to conceive and obviously hold on to the pregnancy as well. When we think about other things, so at this point in time, we've talked about uterine abnormalities and how we can treat that. We've talked about the immune system. We've talked about antiphospholipid syndrome. We've talked about natural killer cells, and we've also talked about celiac disease. The next thing, and it's almost like Sarah's preempted exactly what I was going to talk about, hormonal issues. And hormonal issues play a significant role in terms of recurrent miscarriages, particularly diabetes. And those women who have uncontrolled diabetes will have an increased chance of having a miscarriage. And what we're going to do with the diabetes is not only do we want to control the sugar level, but we also want to maintain a healthy diet and exercise to reduce the overall chance of miscarriage. And we want to maintain a hemoglobin A1C certainly less than 7%. So that might be done in tandem not only with your general practitioner, but in some cases we may need to refer to an endocrinologist who specialises in diabetic management, so that we can benefit, of course, in terms of not only the outcomes in reducing the chances of miscarriage, but of course the benefits that's going to have to the pregnancy. I suppose one of the things from my perspective, not only am I a fertility specialist, but I'm also an obstetrician, and part of my role is not only to see that you have a successful pregnancy, but more importantly, successful in becoming pregnant rather, but also successful pregnancy. And so the ultimate goal for me as a fertility specialist is being able to catch the baby at the end, or catch your baby at the end. And so from that perspective, making sure the pregnancy goes beautifully and we're able to sing happy birthday when the baby's born, but then you're able to care for that bubba in a healthy manner once the baby's born is going to be paramount. So for that, that's part of the reason why we lay the foundations early on before you're becoming pregnant in terms of diet, exercise, stopping smoking, reducing alcohol intake and the like. The other thing is women who have polycystic ovarian syndrome also at a small increased risk. I talked about around about a 15% of a miscarriage rate, generally speaking, that couples would have. Women who have PCOS, it's reported in the literature, can have as high as 20 to 40% chance of miscarriage. And we think that's related to the hormones coming from the brain that are very high, so luteinizing hormone or follicle, and that potentially causes a disturbance in the lining of the womb and the interface between the embryo implanting into the uterus. So again, with PCOS, the management, of course, is maintaining good, healthy diet and exercise and reducing weight in order to mitigate against that risk, and also reducing the insulin. There's a lot of insulin resistance, so we may prescribe metformin in order to reduce that. To Sarah's point before, thyroid disease, and particularly thyroid disease that's uncontrolled, whether it be hyperthyroidism or hypothyroidism, so an overactive thyroid or alternatively an underactive thyroid, can predispose a woman to miscarriages. And so those are the things that we'd be most particularly concerned with respect to miscarriage. Of course, there are other issues with respect to hormonal issues that we would be worried about, and in particular prolactin. So prolactin is the hormone that helps a woman produce breast milk. And so if you have breast milk production outside of pregnancy, there's a possibility, of course, that you have a small tumour in the brain which is benign but is producing a high level of this hormone called prolactin, and that in itself might be predisposing you to miscarriages. So again, as part of a general fertility workup in my practice, I do a recurrent miscarriage screen for the autoimmune antibodies, as we talked about before, and in conjunction with that, celiac disease, but I also look at things like thyroid disease, your insulin levels, your sugar levels, and lastly, also prolactin. Approximately 50% of all miscarriages are the result of a chromosomal abnormality. So to explain this, I want you to imagine that there's a female and a male, and the female and the male have a pair of 22 chromosomes each, and the female will have a X and X, which makes her a female, and the male will have an X and a Y. So think about your chromosomes as if they are in volumes of an encyclopedia. So the woman on this side will have 2 volume 1s, 2 volume 2s, all the way through until we hit 22, and she'll also have 2X volumes. And on this side, the male will have the same, 2 volume 1s, 2 volume 2s, all the way through until we hit 22, and lastly, of course, an X and a Y. And when the couple, whether it be a female with a male donor or a heterosexual couple, of course, who are trying to conceive, when they create an embryo, it's like taking one of the volumes from a bookshelf and putting it into the embryo, and the female will do the same. And you can imagine these books coming out of the bookshelf, each one, until they make a full complement of 22 volumes, a pair of 22 volumes. And the female will, of course, give one of her X's, and the male will give an X or a Y, and that will ultimately determine whether the embryo or the developing baby will be a boy or a girl. Now, what can happen, unfortunately, as a woman ages is that the volumes in her encyclopedia, so her volumes sitting in the encyclopedia, can become stuck. So if we think about the very most common chromosomal abnormality that we know of, which is Down syndrome, that's where the embryo or the developing pregnancy has 3 chromosome 21s. So if you think about this from the perspective of the woman, what ends up happening is she will have her volume 21s are located within her bookshelf, and rather than her just send one volume 1 out, she accidentally sends 2 volumes out. So they get stuck together, And as a woman ages, the volumes become stuck together, and so both of those volumes come out. The male will, of course, send across his volume 21 rather, and that will end up with three volume 21s in this developing embryo. Now, of course, Down syndrome or pregnancies associated with Down syndrome can continue on, but if there's a rearrangement of chromosomes, let's say 3 chromosome 1s, for example, where the female might give 2 chromosome 1s and the male give another chromosome 1, then that will lead to a miscarriage. And so in any rearrangement of chromosomes within the developing embryo, the body naturally understands that this is not a pregnancy that should continue, and so as a result of this, a miscarriage subsequently results. And as I said, around 50% of miscarriages, unfortunately, are a direct result of a chromosomal rearrangement. What can also happen, and part of the reason why we look at the mother and the father, or the male or the female, with respect to, someone's liking my hand action, that's partly because I'm Italian and I'm meant to use hands all the time. It's how I grew up. But part of our chromosomes, you would imagine, are totally solid. So if you look at a volume 14, for example, you imagine that exactly one full volume is the whole volume 14. But what can sometimes happen is there can be a rearrangement of chromosomes within an individual. So, for example, there's something called a Robertsonian translocation, where you get a volume 14 and you get a volume 21. You cut them both in half and you switch the volume half. You switch the two top halves of the volumes together. So when you put them back in the bookshelf, there is a full complement of 22 chromosomes. But if you look down chromosome 14, that'll actually be, or the volume 14, there'll be actually a volume that looks half like it's 14 and half it's 21. And you go down to 21 and there's a half that's 21 and half that's 14. And so when that embryo gets created, one of the partners who has that Robertsonian translocation, in this scenario it's the male, could potentially send out a chromosome 14 that's half 14, half 21, and also send out their normal 21, with the female sending out a 21, and that leads to 3 potential copies of 21. And so that's another very likely example for a miscarriage. So what we do there is we screen both the paternal and the maternal chromosomes to make sure that there's no abnormality in their chromosomes. Now, a lot of people through my Instagram page have posted with respect to factor V laden, MTHFR gene, and whether these have any implications in terms of miscarriage. And it used to be thought that those did have some impact, certainly early on in pregnancy, with respect to recurrent miscarriages. And you may find that your doctor will screen you for clotting disorders. The government has set up a Choose Wisely website, which looks at or tries to educate medical practitioners in terms of the utilisation of investigations in terms of different medical conditions, and one of those is recurrent miscarriages. Thrombophilia, so these clotting disorders, haven't really been shown to cause recurrent miscarriages. So the suggestion that we test for them is therefore diminished. And so whilst some doctors may continue to do so, the evidence is not necessarily there, particularly with the MTHFR gene. So a lot of my patients who have seen traditional Chinese medicine doctors or naturopaths will have been placed on high doses of folate or alternatively folinic acid because of the MTHFR gene. There is a predisposition potentially to clotting with respect to the MTHFR gene, but not specifically with respect to the recurrent miscarriages. Does that mean you shouldn't take the folate? No, it doesn't. You can still continue to take the folate, but it more than likely isn't the reason why there's any suggestion of a recurrent miscarriage. I've talked a little bit about sperm quality, and in particular, males need to, shelter some of the burden, not only emotionally, but also in terms of their own physicality, and also sperm production with respect to recurrent miscarriages. And as I said, sperm DNA fragmentation can also play a part in miscarriages. And so we can combat that by taking antioxidants and such as Menavit, or alternatively being particular about our diet and exercise, reduction in drugs and alcohol intake as well, and of course stopping to smoke. Many women may have an underlying infection, not only within the vagina, but also within the uterus, and that can predispose women to miscarriages. And so in that scenario, some of my patients who have seen me will have had something called an endometrial receptivity assay, and at the same time I also conduct another test called an analysis, which looks at the microbiome within the uterus and any bacteria in the uterus. And in actual fact, I recommend a probiotic in order to restore or normalise the uterine microbiome and also bacteria in order to improve the chances of pregnancy, but also mitigate against the risk of miscarriage. And as I said before, diet, exercise, maintaining a healthy weight range, these are going to be particularly important in reducing the chances of miscarriage. I think the other thing to say, whilst there's limited evidence to suggest that stress plays a role, I certainly know that having a miscarriage and certainly having 2 and then subsequently 3 is particularly distressing for people, and that can't be beneficial not only in terms of your relationship with your partner, but also relationship with other people, and also of course the continual bombardment that we have on terms of Instagram or alternatively social media and even mainstream media with babies being shown everywhere. And certainly I'd encourage anyone who's gone through recurrent miscarriages or a pregnancy loss to seek the advice of their general practitioner, obstetrician, gynecologist, fertility specialist, and particularly a psychologist in order to support them. Many of my patients will know that, I always say to them that when they've had a miscarriage that, there will be brighter days ahead, but you do need to surround yourself with a very supportive unit so that you can get through those difficult patches. So when and if, unfortunately, you've had miscarriages, you see a gynecologist or a fertility specialist specifically related to your recurrent miscarriages, what we do is we take a thorough and detailed history. And what we are particularly wanting to focus on, of course, is your history of pregnancy, whether there's been a heartbeat, how many weeks you were when unfortunately you had a miscarriage, and has there been any opportunity to send a sample of tissue off for chromosome analysis. I think I was quoted in the media with respect to a rapid test looking at the tissue that's taken at the time of a curette or a surgical procedure in order to remove a miscarriage, and the benefits that potentially has to the woman in terms of their own psychological well-being, knowing that it's not something that they've done, but actually a chromosomal abnormality that's occurred within the embryo. And of course, that's no fault of your own if that's occurred, and it's nature's way of protecting you from a child that potentially would be born with severe disability and or illness. So having that test available or knowing that there's a chromosomal abnormality, I suppose, provides comfort to a lot of women. So knowing that in terms of your history is particularly important, because that'll also impact on our understanding of why we need to test the mother and the father, or the male and the female with respect to their chromosomes to establish whether there's any abnormality. We'll also look at the cycles, how often your cycles are coming, if there's any history of abnormal menstrual bleeding, which might be indicative of any underlying concerns with respect to the uterus, and so whether there's any fibroids that might be predisposing to abnormal menstrual cycles. And then in terms of an examination, we'll ask things like if there's any breast milk production or milk production from the breasts, and are there any signs or suggestions potentially of polycystic ovarian syndrome. And then looking specifically at what I talked about before, I have a little acronym that's called Packet D. This little acronym is tells you the sort of investigations that we would do as a fertility specialist or gynecologist in terms of looking at causes with respect to recurrent miscarriages. So we're looking at prolactin. We'll look at the androgen profile, so testosterone levels that might particularly predispose a woman to miscarriage because she's got PCOS. We'll look at karyotype, so K standing for a karyotype or a chromosome analysis on the couple. I stands for imaging, so an ultrasound scan, looking also potentially at an X-ray that may also show us whether there's hysterosonography, which shows us the inside of the uterus to see if there's any fibroids or alternatively any polyps or any abnormality within the structure of the uterus. And also I stands for immune concerns, so We talked about Antiphospholipid Syndrome. We talked about Celiac Disease as well. T, or packet, so P-A-K-I-T. T stands for thyroid disease. We look at thyroid, we look at thyroglobulin, thyroid peroxidase antibodies as well. And D stands for diabetes. So we'll do a thorough screening in terms of your blood workup and profile to determine whether there's anything that particularly is of concern and can be mitigated and reversed in order to improve the overall chances of pregnancy. The next thing, as I talked to you about before, is an ultrasound scan, and also then working out whether there's anything specifically within the uterus. And if there is, then undertaking a hysteroscopy to have a look inside the uterus. But in addition to that, also determine whether we need to resect a septum or remove a fibroid. And those things will be done in conjunction, obviously, with your gynecologist or fertility specialist to improve the overall chances of pregnancy. I think most of you would want to know specifically about what we then subsequently do. And of course, what we do in terms of management will be predetermined, I suppose, by what we find in terms of investigations. So I've already alluded to what we do if there's a uterine abnormality in terms of surgery to possibly correct that. With the antiphospholipid syndrome, as I've explained before, low-dose aspirin, Clexane are the mainstay in terms of treatment with respect to that. Hormonal treatment, obviously adjusting for thyroid function, whether that be up or down, either trying to reduce and normalise the thyroid function or increase the thyroid function with thyroxine is going to be particularly important. And prolactin, if we've got a high prolactin level, obviously doing a scan to try to see if there's any particular pituitary tumour that predisposing you to having a high prolactin level, and then treating that with a tablet in order to reduce the prolactin level. Other remedies that are postulated, and some people will be seeing specialists that may recommend this, will be progestogen. And as I said before earlier on in this talk, there is a small study looking at the use of progesterone to reduce the chance of recurrent miscarriage. Again, there's evidence to suggest that it possibly may work, and certainly evidence to suggest that it's not going to work. And it's always a fine balance between trying to work out specifically whether there's any harm that you do necessarily to a woman who potentially needs the progestogen. So I tend to utilise progestogen in the setting of a threatened miscarriage. So if a woman is having some bleeding, then I'll try to introduce progestogen to try to increase that level to the point where try to mitigate against the risk of miscarriage. And then, of course, immunotherapy such as intralipids and steroids. Once again, the evidence for that is 50% one way, 50% another, and the discussion that you would then have with your fertility specialist or gynecologist with respect to utilising that medication, those medication would be weighed up against the potential risks and also benefits. So, rather than me specifically say that it's the right thing, I think it's a discussion you have individually with your medical practitioner. Then comes, I suppose, the role of IVF in all of this with respect to recurrent miscarriages. And as I said before, it is very unfortunate for a woman to experience one miscarriage, let alone 3 miscarriages. And the unfortunate reality is that the more miscarriages you have, unfortunately, there's a higher predisposition to a subsequent miscarriage. So that if you've had 3 miscarriages, the chance of having a 4th miscarriage is around 33%. And the vast majority of the reasons, as I said, 50% will relate to a genetic predisposition or the way the chromosome is formed with those volumes of an encyclopedia. So IVF utilised in this scenario is particularly vital because it reduces the chance of miscarriage from 33 or 35% down to 6%. And the way that we do that is we actually do something called embryo screening, where we actually take a sample of the blastocyst, which is a day 5 embryo. We take about 4 or 6 cells. We open the cells up, we extract the DNA, and we amplify that DNA so that we can see if all the volumes of the encyclopedia within the embryo match up, so that there's 2 volume 1s, 2 volume 2s all the way through until we hit 22, and that there's an X and Y chromosome or an X and X chromosome if it's going to be a female. And if we have a normal embryo, we know the chance of pregnancy is exceptionally high at around about 50%. But more importantly, for those women who've unfortunately suffered from miscarriage, is a massive reduction in the chance of miscarriage from around 35%, as I said, to 6%. And so the utilisation of that technology to reduce the chance of miscarriage is exceptionally high. It also means that the interval to becoming pregnant is also shorter, because we're not taking time to put in embryos that potentially will have a chance of miscarriage or alternatively fail because they are simply chromosomally abnormal. So there is certainly a role for IVF if we find that there's a strong predisposition to miscarriage, and particularly related to a woman's age. The next thing is, how does recurrent miscarriage potentially affect ongoing pregnancies? If you have had a miscarriage, the chance of an ongoing pregnancy in the first 3 months after a miscarriage is 70% greater. So in my practice, I certainly encourage women, if unfortunately they've had a miscarriage, to continue to try, because I know that there is a strong possibility they'll have a successful pregnancy in the coming months. And there used to be historically evidence to suggest that you should wait 3 to 6 months, a period of time, before you did become pregnant. But new evidence suggests that it's actually okay to get pregnant straight away. And in fact, there's been many of my own patients who've had a miscarriage and not even had another period before they've subsequently gone on to have a full-term pregnancy, which is absolutely fantastic. The other thing is what impact that potentially has on future pregnancy. So if you've had recurrent miscarriages in the past, then there is the possibility of or an association with fetal growth restriction and preterm birth. And this is why it's particularly important not only to surround yourself with a very good fertility specialist, but also, in addition to that, also an obstetrician who can care for you during that pregnancy journey and try to mitigate against the risk of fetal growth restriction and also preterm birth. So that means frequent monitoring during the pregnancy. And most good private obstetricians now will have access to an ultrasound machine. In my own practice, I scan patients at their appointments to ensure that the baby continues to grow, and making sure that, of course, there isn't any element of growth restriction. And if we're concerned about the growth of baby, then obviously we take measures in order to reduce the chances of the baby being unwell, of course, and then bring Bubba out a little bit earlier if need be. I'm now going to run through some people's questions. So if you have questions, please fire them off. People have sort of been posting, and I'll try to cherry pick some of them so that we can I think I sort of answered the first question with respect to the quality of the eggs. The quality of the eggs is, generally speaking, a function of a woman's age, and yes, I do think that unfortunately that does predispose a woman to miscarriage. Someone's asked specifically about 2 consecutive miscarriages with 2 different donor eggs. What further tests would you recommend? And I've suggested natural killer cells. Again, natural killer cells are negative. I wouldn't necessarily be retesting them. And again, with respect to the evidence in terms of natural killer cells and their impact on recurrent miscarriages, again, the evidence is quite poor. Emma's asked specifically about being 32 with 1 successful pregnancy in 2018, and this is called secondary recurrent miscarriages, and then 3 miscarriages in the past 12 months. And so again, the chance of an ongoing pregnancy in the setting of a woman who's previously been pregnant and carried a baby to term is very, very high. But of course, we want to exclude any of those conditions that I talked about before. Women will have had, for example, this is a very classic example where a woman gives birth, maybe has a bit of retained placenta, and that retained placenta calcifies within the uterus. And very similarly to what I talked about before, this baseball pitch or this fibroid sitting within the cavity, that calcification of placenta potentially can predispose to miscarriage. And of course, going in there, having a look inside, removing this calcification will improve the chances of pregnancy. Someone unfortunately has had miscarriages at 12 and 13 weeks. And of course, obviously having had other pregnancies in the past predisposes you to an ongoing pregnancy in the future. So I think I've answered a fair few of these questions that people have asked here with respect to specifically miscarriages. I think in terms of your overall individual status, in terms of your own individual health issues that you may have with respect to fertility, I think it's really important that you do see someone who can take the time to listen to you, can explain things in a way that makes you understand why things unfortunately are occurring, or more particularly what management plan is going to be put in place in order to get you the ultimate goal, which is to become pregnant. But as I said before, really becoming pregnant is merely a stepping stone, of course, to being a mum and a dad. So that's going to be the most important thing. Someone's asked about metformin, and as I said, metformin's used quite well with respect to obviously reducing insulin resistance and used in PCOS, and that would be something quite suitable in terms of miscarriage. Someone's asked about Generation Plus tests. I suspect that's genetic testing, particularly related to genetically inherited conditions, not specifically related to recurrent miscarriages, but I'd certainly be recommending that a woman would do that prior to pregnancy. In fact, both RANSCOG and also the general practitioners, both of us recommend that a woman and a couple should consider genetic carrier screening, particularly cystic fibrosis, spinal muscular atrophy, and Fragile X. All right, someone's asked about a probiotic. I tend to recommend something called Canesflor, Canesflor. It's a probiotic. Unfortunately, it's a vaginal probiotic. Unfortunately, only available online. So if you can Google it, you can find it. Alternatively, if you need to, you can contact my rooms. Someone said I had a polyp removed and had a vasovagal, so it was done while awake and waiting surgery, which pretty much I agree with. You probably should have it as a general surgical procedure as opposed to being awake for it. Prenatal vitamins are particularly important. Folic acid is particularly important as a prenatal vitamin to reduce the chance of neural tube defects. Many of you will also be advised by your fertility specialist to take antioxidants, so things like coenzyme Q10, vitamin D, and fish oil. And as some of you who are Melbourne IVF patients will know, we're currently running a trial where we're placing the embryos in antioxidants themselves, and the preliminary reports show that these embryos are surviving to day 5, a lot more of them surviving to day 5 rather, and we're also having higher pregnancy rates. So utilising the benefits of our research team headed by, and also our laboratory headed by Professor David Gardner is particularly important. As a unit, Melbourne IVF prides itself on the excellent scientific research that we do, and that in part improves the overall outcomes of IVF treatment, not only for our patients, but of course also for the broader community. How successful is IVF at the age of 44? Again, it's an individualised perspective. If we find a genetically normal embryo, then the chance of a woman becoming pregnant at the age of 44 is the same as if she's 30. So if you have a genetically normal embryo, that embryo implanted in the uterus is around 50%. Someone's asking about chemical pregnancies. So chemical pregnancy is when an embryo has formed, or rather sperm has met an egg and it started to produce pregnancy hormone, but unfortunately soon after you having missed a period, you end up getting whilst you must have a positive pregnancy test, you end up miscarrying, so you end up having your period a little bit later. So someone's talked about endometriosis and adenomyosis. I think that's a huge thing, and I think in terms of any woman who's suffering from pelvic pain or alternatively from heavy menstrual bleeding, they should see a gynecologist or fertility specialist. No woman should live in pain in terms of their periods. If that's impacting on your quality of life, and what I mean by that is you're taking time off work, you're having to pop pills every time you're having a period, or alternatively you're having concerns with fertility treatment, then seeing an advanced laparoscopic surgeon, someone who can perform laparoscopic surgery and remove endometriosis, is going to be very particularly included. And so, even in my own practice, in conjunction with Dr. Lyndon Hale, who's the medical director of Melbourne IVF, the two of us operate together, and we will resect all the endometriosis. If there's endometriosis on the bowel, we'll remove the endometriosis from the bowel. And it's really important to look at who your gynecologist is and whether they can perform that type of surgery. So we've got some more questions coming in about 36-year-old conceiving and having successful periods. So, a 36-year-old woman trying to get pregnant, the overall chance of pregnancy is around 15 to 20% per month. And people often think that means they'll get pregnant straight away. I certainly would recommend that a 36-year-old try to, at least for 6 months, if there's no issues. And really, when you think about fertility as 5 things that you need to have. You need to have sex, you need to have sperm, you need to have a receptive uterus, you need to have open tubes, you need to have ovulation, and you need to have patience. And so assuming all those components, and patience as well being one priority as well, are all there, then please continue to try. Now, if you're under the age of 35, I'd encourage you to try for 12 months. And if you're over the age of 35, then 6 months before you seek the advice of a fertility specialist. But if you're worried, for example, you're having heavy periods, or you've got pain, or your partner in terms of a male, if you've had concerns with the testicular torsion in the past, or undescended testes as a child, anything that potentially you just twig and say, well, no, this doesn't, it doesn't feel right, then seek advice earlier rather than later. I'll keep going through some of these questions. Has there been any advancements? I've had genetic testing, have to do. So I think I've answered a lot of the questions here. Is Panadol okay for pregnancy? Of course, Panadol is okay for pregnancy. There is some, if you Google it, some suggestion that there was a link between autism and Panadol. I can tell you now that's not true. I'm going to finish off now, and I hope that I've answered most of your questions. I probably will also follow this up with a Instagram question that I'll post over the weekend, so that if you do want to follow me on Instagram, please go to my Instagram page at Dr. Joseph Sgroi, and you can find me on Instagram. I tend to post a lot there. I'll provide you not only tips with respect to fertility treatment, gynecology, but also obstetrics or pregnancy care, and you can ask me any questions as well. I'll probably post a little bit about recurrent miscarriages in light of the discussions that we've had today. As I said at the very start of my talk, and I'll conclude at the end, it's the most distressing thing, I think, as a medical practitioner, particularly in the field of women's health, is unfortunately being involved with couples who have had recurrent miscarriages. But of course, the sadness that we might feel really pales into insignificance when we understand that the impact that has on the woman and also her partner. And a lot of people feel as though they can cope by themselves in terms of miscarriages and pregnancy loss, but I really encourage you that if you've gone through even one miscarriage, that you seek the advice of someone who can support you, because I think there's always the fear the next time around that it might happen again. And having that support in place with someone that you can trust in order to get you through, that emotional heartache is going to be particularly important, not only in your mental health, but also your relationships, and most particularly in the enjoyment of the next pregnancy. It's really hard, and all of us as fertility specialists know that it is difficult for you all, and we're always striving not only to get you to the ultimate goal of pregnancy, but also to support you from a mental health and well-being perspective as well. Thanks very much for your time today. I hope you have a wonderful evening and stay safe. Bye for now.